Welcome back to the second class in this internal medicine series. Today we will look at valvular heart diseases, and this is going to be building up from the first class about the structure and function of the heart. We'll start by giving a very general overview. Okay, now we have four main valves that are affected: aortic, mitral, tricuspid, and pulmonary. And what can happen to these valves is that it can become stenosed, or we can have insufficiency or regurgitation of that valve. Stenosis literally means the narrowing of the valve, and you therefore have the obstructed forward flow of blood. Regurgitation means you have an incompetent valve, in other words, a valve that doesn't quite work like it should, and you have the backward leakage of blood back into where it started from. So what we will cover is we will talk about murmurs, and we will talk about each valvular disease. We'll talk about the etiology, pathophysiology, symptoms and signs, investigations and treatments. I just want to talk about some heart murmurs. What are these murmurs? So these murmurs are caused by turbulent blood flow across diseased valves. So you can have murmurs during systole, or you can have murmurs during diastole. Systolic murmurs are generally to do with the forward flow of blood. So you have aortic and pulmonary stenosis, mitral and tricuspid regurgitation. These are what will give you a systolic murmur that you can hear. And diastolic murmurs deal with the backward leakage of blood. So that is aortic and pulmonary regurgitation and mitral and tricuspid stenosis. So all of these things are best evaluated by your physical exam during auscultation. And nowadays, if we can't hear something from the physical exam, we do an echo to look at the patency or the competence of the valves. So throughout this whole lesson, we will talk about different diseases, but I just want to really focus on the core principles of regurgitation and stenosis and what it does to the heart. Okay, so regurgitation causes volume overload changes. Okay, so how does it do this? Blood flows backward when it should not. So the receiving chamber must handle extra volume of blood. So what that extra volume is called regurgitant volume. And in order for the heart to adapt to that change, it dilates. So that chamber dilates to accommodate that extra volume. And what we see is eccentric hypertrophy. So we have new sarcomeres or muscle tissue that is arranged in series. So if you think back to physics back in school, you have a series circuits, so it's in one line. So you have new sarcomeres that are added in one line, and this enlarged cavity will have relatively normal wall thickness. Okay, and we will talk about how it all goes wrong later, but I really want you to understand that regurgitation causes volume overload changes to the heart. Stenosis causes pressure overload changes. So what happens here is that the narrowed valve means that the chamber upstream must generate higher pressure to push blood through. So the chamber has to produce a much higher force to push that blood through to its intended destination. So it's a pressure. And what happens in stenosis is that we have concentric hypertrophy. So we have new sarcomeres or muscle tissues that are added in parallel. And what you will see is thickened walls, small cavity, and stiff ventricle. The whole reason why the heart does this is to enhance contractility, because by enhancing contractility, you can get over that higher pressure and push more volume of blood through. So initially, these patients don't really show many symptoms, but later it can progress, and it can progress very quickly and to lead to failure. So once again, stenosis causes pressure overload changes, right? I hope these two things will make more sense once we go through the class. Anyway, this picture here shows you the auscultation points and what each auscultation point means when in context of your physical exam. So the mitral, so you can see mitral area, tricuspid area, pulmonary area, aortic area. What are you actually listening to? You're listening to the respective valves. So when you put your stethoscope on those points, if you hear a particular murmur, you can say with reasonable confidence that it is, say, a mitral stenosis, say a aortic stenosis. So this is why when you have the patient in front of you, your physical exam has to be perfect. Your technique has to be perfect. There is a reason to the madness. So make sure, I'm just showing you this picture. I'm sure you guys already know this, but it's just a reminder. And this is what we're actually intending from this. This is how you'll know what murmur is causing, showing damage to which valve, if there is damage. So we'll kick things off by talking about mitral valve disease. So as you know, the mitral valve is the atrioventricular valve between the left atria and the left ventricle. So we'll talk about stenosis first, but I want you to know about the what a normal valve, the area of a normal valve is. So it's usually around 4 to 6 centimeters squared. Now, if you have stenosis, what we consider severe mitral stenosis is an area less than 1 centimeter squared. In terms of etiology, the most common cause of mitral stenosis is rheumatic heart disease, especially after especially after Group A streptococcal infection. What we see is that we have thickened leaflets and commissural fusion. So thickened leaflets will make it very difficult for that valve to open. And commissural fusion is essentially a situation where your bicuspid valve, your mitral valve, sits together, and it sticks together due to inflammatory deposits. And quite rarely, you will also, within mitral stenosis, there are some other causes. So you have congenital causes, you have calcification, you have tumors. So just remember that severe mitral stenosis is any stenosis where the area is less than 1 centimeter squared. Now, that is important because this influences whether we medically manage this patient or we surgically manage this patient. So just keep that in mind. Now, before looking at the pathophysiology, I want you to just cast your mind back to the systemic and pulmonary circulations. So just remember that pulmonary circulation is in a loop. Now, when we look at the pathophysiology, we have the mitral valve narrowing or mitral valve stenosis. This increases the left atrial pressure. So blood is coming into the left atria, and because the mitral valve is not opening properly, you have more and more blood go in there, increasing the intra-atrial pressure. And in order to push through the mitral valve, the left atria undergoes some hypertrophic changes. So we have said before that stenosis is a pressure overload. So you will have concentric hypertrophic changes. So it's in parallel. The new sarcomeres will be in parallel. So what you have is left atria will start to have new changes. It starts to have these concentric hypertrophic changes. And what this causes is, yes, blood will go into the left ventricle, but it means that the pressure gradient between the pulmonary artery and the left atria will increase. So it's much harder for blood coming in from the pulmonary circuit to enter the left atria. So this increases pulmonary circuit pressure, and it causes congestion. It causes pulmonary hypertension. Um, Now, when you have pulmonary hypertension, think about it. As I said, it goes back in a loop. It causes the right ventricle to start to strain. It strains because it needs to create a force that overcomes the pulmonary venous pressure. So, so the right ventricle will also go through hypertrophic changes. And a long time of this happening will eventually cause right-sided heart failure. Now, I hope that makes sense. But in terms of complications, what happens is that when the atria goes through its enlargement, its hypertrophic changes, it becomes less conductive. We lose atrial kick, and what we expose the heart to is atrial fibrillation. Now, atrial fibrillation is not something that we want because it increases how long blood can stay inside the atria, and therefore it increases the chance of a thromboembolism to be produced. So think back to Virchow's triad, right? The triad of hypercoagulability or triad of coagulation. So the other complication is that um, stenosis can reduce left ventricular end diastolic volume. So the volume of blood that is in the left ventricle after diastole, so the ventricular filling. Now, therefore, when we have systole does not produce enough cardiac output. And this effect is especially felt during exertion, during tachycardia, because this patient could become syncopal if they don't get enough, say, perfusion to the brain. Says that this patient can faint, even that this patient can have cardiogenic syncope, and this is, the hypoperfusion of the brain is called cerebral hypoperfusion. So this is what causes syncope. And also this can be very bad in pregnancy as well, because the fetus does not receive enough blood. So these are the complications from stenosis. Atrial dilation, which may go on to cause atrial fibrillation, and also reduced end diastolic volume, meaning reduced cardiac output. Now, what are the signs and symptoms that the patient may come in with? So you have a patient in front of you. Some of the symptoms that you might see in a patient with mitral stenosis is dyspnea, so dyspnea or shortness of breath, hemoptysis, so blood in your sputum, palpitations or the awareness of a heartbeat, and fatigue or edema. Now, remember, your auscultation point will show whether or not you have mitral stenosis. But we have a little sound clip which I'll show you, which may help you, which you should try to kind of recognize in a patient. But that's for the future. Anyway, dyspnea or shortness of breath. What's that caused by? So when we have dyspnea, it's because, as I spoke about before, we have pulmonary venous congestion due to, and this increases the pulmonary capillary pressure. This causes the intravascular fluid to leak outside of fenestrations of the capillary and fill the heart. This causes pulmonary edema. And therefore, the patient starts to feel very short of breath because there's less functional area for gas exchange to occur. Now, hemoptysis, so blood in your sputum. The reason why this happens, this is a bit more end stage, to be honest with you, but this happens because when you have increased pulmonary venous pressure, you can rupture your bronchial veins, and more pressure can occur due to pulmonary hypertension. So if you rupture your bronchial veins, it's a good sign, and you have blood in your sputum, it's a pretty good sign that there is some sort of end stage kind of mitral stenosis going on, or severe mitral stenosis going on. Palpitations. So palpitations is an awareness of a heartbeat. That's what it clinically that's what it means. Now, palpitations can be especially prevalent if that patient has atrial fibrillation. Now, if they've gone through hypertrophic changes to the left atrium, then that patient is more likely to have AF, and therefore that patient is more likely to experience palpitations. I've also written fatigue and edema. And fatigue, as I said, as I mentioned earlier, this entire process reduces your cardiac output over time. And therefore, we have reduced systemic perfusion of blood. And if you have reduced systemic perfusion of blood, it means that there's less blood going to your tissues. And therefore, there's, in terms of your brain anyway, there's less blood going to your brain to meet metabolic demand. And therefore, you can start to feel more tired, fatigued, and this can actually develop into syncope, where you don't get enough blood at all, and therefore you lose consciousness. Often with patients who come into your clinic, they will actually start to say, I feel really short of breath. I'm so much more tired than usual. I can't walk as long as before. Which is another way to say that they have reduced exercise tolerance. So these are kind of things that they will say to you when they're describing their symptoms. And when you correlate that clinically, it could be because of dyspnea, palpitations, fatigue, edema. Okay. Now, in terms of signs, we will hear a diastolic murmur, a rumbling sound during diastole. It's like a trickle. We can also do other investigations as well, such as chest X-ray, that will show an enlarged left atria in comparison to the left ventricle. And in the ECG, you'll see bifid P waves or P mitrale, but more often than not, you see AF. Okay. Oh, I got a nice video here. Can you all hear that?
Yeah.
Great. That's such a great video from med school. That saved me in med school. So I hope you could hear that diastolic rumble. Okay. Right. So in terms of investigations, echo. So echo is what mainly we go to, especially if we suspect somebody has a valve-related murmur. To really confirm it, echo is best. So within echo, you can actually assess the valve area. so therefore grade this patient's mitral stenosis. And you can also have a look at the sizes of the chambers, so especially the left atrial chamber, left atria, and also the right ventricle as well. ECG, of course, as I said, you mainly tend to see AF. You can sometimes see P mitrale. The next one is chest X-ray. So chest X-ray is, to be honest, in clinical practice, is done to rule out if the patient has any signs of pulmonary edema or not. And sometimes you also do cardiac catheterization as well, but that's a bit that's quite advanced, and often it's not something you do immediately. You will do that as an outpatient. In terms of treatment, what we can do is percutaneous balloon valvotomy. So this is literally a catheter through the radial or the femoral artery, and we push something through all the way into the heart, and we'll replace it essentially. We can also do surgical valvotomy. Now, surgical valvotomy, you have to make sure if the patient is surgically fit or not. So that assessment has to be made. You can also do mitral valve replacement. Again, this can be an open heart. This is an open heart surgery, and also MitraClip for non-surgical patients. I just want to also just note that mitral valve replacement, if the valve is metallic, it's important that we give them anticoagulation, and the anticoagulant has to be warfarin. So mechanical heart valves, you have to give warfarin because DOACs are contraindicated. And medical management. So in patients like this, we have to manage them medically anyway. So we give diuretics. So diuretics will relieve pulmonary congestion or pulmonary edema, any peripheral edema that might have been caused as well. Rate control. So basically, the point of rate control is to prolong diastole. So encourage ventricular filling. To sustain cardiac output. And if this patient has gone into AF, we want to also control that rhythm and stop them from having a thrombus. So it's just kind of like a protective measure that we can do. So diuretics, rate control, and anticoagulation is what we do. Right. So the next valvular problem is mitral regurgitation. So as I said earlier, regurgitation is a volume. You're going to see volume overload problems to the heart. So regurgitation means literally a leaky valve. It's because of incompetence. So I split this into two ways. So we have primary or valve-related problems, and secondary, which is due to functional problems of the heart. Now, valve-related, the most common way you can have mitral regurgitation is through mitral valve prolapse, and so that's just like the rupture of it. The other ways we can have it are infective endocarditis. So remember, with valves are covered with endocardium. So inflammatory changes or infective changes could also spread to the valve. And this can cause inflammation, and this can cause the valve to become incompetent. We can also have leaflet or annulus or chordae or papillary muscle dysfunction. I've also written here myxomatous degeneration. So this is really associated with people who have genetic disorders like Marfan syndrome, Ehlers-Danlos syndrome. So this is a what myxomatous means is that it's a connective tissue disorder. So it's a non-inflammatory heart valve disease, where fibrous tissue will break down, and we have mucoid substances accumulating, and this leads to thickening of the valve, and sometimes and then later prolapse of the valve, and then sometimes even the rupture of the valve. So this is something you may see as well. So especially in patients with Marfan syndrome or Ehlers-Danlos syndrome. And again, we've spoken about rheumatic disease. So rheumatic disease leading to fibrosis of the leaflet, that can also go on to cause regurgitation, and post-MI papillary muscle rupture. So we can have after an MI, you can have death of certain parts of the muscle, and you can therefore have the death of the papillary muscle as well. So papillary muscle which deals with the closure of the valve. If it doesn't close properly, you can have the leaking of blood back into the chamber, back into the atria during systole. Right. Excuse me. As I said, so we have secondary causes as well. So in terms of secondary causes, these are kind of functional problems. So when we have left ventricular dilation and dysfunction, especially in dilated cardiomyopathy, we have left ventricular remodeling. So left ventricular hypertrophic changes, for example, is an example of remodeling. So when that happens, the heart becomes stiff, becomes less compliant. So it produces it tries to produce a really high systolic pressure. And when that systolic pressure is applied, sometimes a small volume of blood can actually push past the mitral valve back into the atria. So this is something else that can happen. Now, in terms of pathophysiology, an incompetent mitral valve can cause the left atria to have more volume than it should. And therefore, what we see is the enlargement of the left atria, and this reduces the pressure gradient between the pulmonary circuit and the left atria, and it promotes congestion. So what it then causes is that when the valves do open finally, you have lots of blood that flow down into the left ventricle, and this causes left ventricular dilation and left ventricular remodeling. And this leads to heart failure. So you can have compensatory changes, and you can have decompensatory changes. So compensatory changes is what left ventricular remodeling is. So it's essentially hypertrophy. So compensatory changes, literally, they don't show up in a patient like that. Their symptoms seem to be stable. They may not even know that they have this. But decompensation is when we tend to see a symptomatic patient come in. So basically, mitral regurgitation leads to heart failure because of decompensation, because excessive dilation will increase the wall stress on the left ventricle, and systolic dysfunction can develop. So systolic dysfunction will mean that the left ventricle can't contract as properly, and therefore there's less forward output or less cardiac output, and there's more backward transmission of blood back into the left atria. This leads to left atrial dilation, and this leads to left atrial pressure to increase or remain high. And if it remains high, what it means is that there's more pressure that the blood from the pulmonary vasculature needs to overcome to enter the left atria. And what this will cause is an increase in the venules and arterioles, so much so that you have fluid seep into the lungs and cause pulmonary edema. Now, if there is an increase in the pressure of the pulmonary circuit, the right ventricle will have to produce a force that is higher than it normally is, and it would have to also go through remodeling to become stronger, to exert a bigger force to overcome the new pulmonary circuit pressure. So the right ventricle will also go through right ventricular hypertrophy. Now, over time, what this can actually cause is biventricular failure, and then eventually cardiac death. Now, if somebody goes through biventricular failure, we can actually do something. We can actually do something called BiVAD. We can put them on something called a BiVAD. So that's doing the function of the right and left ventricle, and allows us to kind of just take over the function of the right and left ventricle until we can decide on what to do next for that patient. Okay, so let's keep going. Signs and symptoms of mitral regurgitation. So once again, we have dyspnea. We have spoken about how dyspnea occurs. So this can occur because of increased pressure inside the pulmonary circuit, causing fluid to seep out into the lungs. So this patient will feel very short of breath on exertion. They may feel fatigued. Palpitations. So palpitations mainly, again, due to atrial fibrillation, but remember, palpitations is an awareness of a heartbeat. So the other thing here is orthopnea and paroxysmal nocturnal dyspnea. So orthopnea is basically shortness of breath when you lie down. How does that happen? So that happens because gravity, when you lie down, gravity redistributes blood to the lower extremities and the splanchnic veins, and this increases the venous return back to the heart. Now, in an already failing left ventricle, it can't handle the extra blood that needs to be that is being forced into the heart, and this causes left atrial dilation and an increase in the pressure inside the pulmonary circuit. So what would happen is that you would have fluid pass into the lungs, and this patient suddenly feels very short of breath and needs to kind of sit upright in order to feel a little better. So this is orthopnea. So that's when you lie down. So on the examination table, something that you can do is you can just literally when you put the table down, so the patient, say this patient is already upright, you can put the examination table down, and you can see that this patient, when they lie down, start to feel a bit more short of breath, and they'll tell you, obviously, but they'll start to feel a bit more short of breath, and this is a sign that, you know what, maybe this person might have a valvular problem or something else going on. So paroxysmal nocturnal dyspnea is essentially, paroxysmal means on and off, nocturnal means night, and dyspnea, obviously shortness of breath. Now, so these patients essentially wake up from their sleep with shortness of breath. Now, why does this happen? This happens because when you sleep, you have reduced adrenergic drive. So there's the left ventricle doesn't have the same sympathetic support to contract. So there's less contractility. When there's less contractility, you have less cardiac output, and there's this delayed pulmonary congestion that happens during sleep due to the redistribution of blood. So these patients will wake up and they start to have shortness of breath and they feel really uncomfortable. But this is and this is what we call paroxysmal nocturnal dyspnea, because it usually happens during sleep. Now, in terms of signs, so from your physical exam, what you will hear is a pansystolic murmur at the apex, and this radiates to the axilla. You may hear an S3 gallop, and you may see signs of left or right-sided heart failure in a patient with chronic mitral regurgitation. So one of those things is your jugular vein could be dilated. So when the patient is in front of you, you should just check their neck. Ask them to move their neck left and right 45 degrees, and when they're looking away from you, just have a look. Is their jugular vein dilated? This is usually a sign that there's some sort of valvular disorder going on, or some sort of heart failure. Well, this is a heart failure symptom, but something's going on. Okay. Now, there are, of course, many other things that are handy for us now in this age. So in terms of investigations, a chest X-ray. It's a very basic thing, but we can do a chest X-ray. And if we do a chest X-ray, we could see left atrial and left ventricular enlargement. We may see calcification. An ECG, you may see left ventricular hypertrophy. You might see some delays. You might see some heart block changes. I'm not going to go into that in the ECG changes just yet. We'll do that in another class, but just have that in mind for now. But still, the best way to find out if somebody has regurgitation or not is using an echo and also a Doppler alongside it. So a Doppler would look at the flow of blood. Echo looks at kind of the valve area, the competence of the valves, and also looks at the chambers as well. So that's pretty accessible in most hospitals in the UK. So it's something that you could do. And also, when you take bloods, it's important to add on a BNP because it's important to check for signs of heart failure. So, this can also help us classify this patient to see if they have mild, moderate, or severe mitral regurgitation. Okay. And treatment is also similar to mitral stenosis. So, giving diuretics, something to control the blood pressure, so ACE inhibitors, and also anticoagulation, especially if that patient has an AF. So in this case, I might give them apixaban. I think that's what our NICE guidelines state, to give apixaban if that patient is in AF. Now, if they have mitral regurgitation, we can consider surgical repair or replacement. But we don't, unless that patient is super symptomatic, we don't go straight for the surgical option. So it's only if they have an acute, severe mitral regurgitation do we do emergency surgery. And once again, we can, one of the more, especially in patients who aren't really surgically fit, mitral clip might be a very good option. If not, open heart surgery and changing the mitral valve. And again, from the previous slide, if it is a mechanical valve, we anticoagulate them with warfarin. Now, I've got two videos here that I feel are very, very helpful. So the first one is going to talk about the pansystolic murmur, or as it's titled here, the holocystic murmur, systolic murmur. And the other the other clip is about the mitral valve prolapse. So let's play this. Okay. So that's the pansystolic murmur that we hear. And this is just a little tidbit, a bit of an extra, the mitral valve prolapse. Literally means turn to the side. Okay. So I hope that that sound clip and the information around it was quite helpful. Oops. Okay. Now, let's move on to aortic valve disease. So, as you know, the aortic valve is the valve between the ventricle and the aorta. So the blood inside the left ventricle is oxygenated, and this is now going to go to the systemic circulation to provide blood to the rest, all of the other tissues in the body, the internal organs, the brain, etc. Now, aortic stenosis, the aortic valve, normal valve area is about 3 to 4 centimeters squared, and in severe aortic stenosis is less than 1 centimeter squared. Now, aortic stenosis is the most common valve abnormality in the developed world. So you see quite a lot of this, and you will see quite a lot of this in your clinical practice. The main cause of this, in terms of etiology, is calcification. So calcific degeneration is the main cause of this. Of course, again, you could have changes due to rheumatic disease. And congenitally speaking, you could also have a bicuspid valve, because obviously aortic is a tricuspid valve. But the main cause for aortic stenosis is calcific degeneration. Now, so as I said before, what are we going to see in the heart due to aortic stenosis? We're going to see pressure overload changes. Okay, so we're going to see concentric hypertrophy. In other words, the sarcomeres lining around the left ventricle in a parallel manner. So what in terms of pathophysiology, what we see is that we have the obstruction to the outflow of the left ventricle. So therefore, to kind of overcome that obstruction, the left ventricle has to increase its systolic pressure. And in order to do so, we go through concentric left ventricular hypertrophy. Now, patients generally manage to maintain cardiac output for a long time, because this concentric left ventricular hypertrophy is a compensatory change. But eventually, what can actually happen is that the left ventricular end diastolic pressure increases so much that in order for blood to pass from the left atria into the left ventricle, the left atria also has to go through changes. And we also see pulmonary congestion. And this eventually leads to left ventricular failure. So the concentric left ventricular hypertrophy causes the left ventricle to become stiff. And this newly stiff ventricle will make diastolic filling quite difficult. Um, the diastolic filling volume, which exerts pressure that is then used to push the blood into the aorta, increases more rapidly. And this pressure, this increase in pressure, is transmitted backwards into the left atria. So the left atria also has to undergo dilation. The dilated left atria must generate higher pressure to overcome this left ventricular pressure, and the left atria stretches and dilates, and the increased backward pressure causes what will transmit again backwards into the pulmonary circulation. The capillary pressure rises, and then we see pulmonary edema. And these people and the symptoms again is quite similar to everything that we've spoken about before. We can see shortness of breath, so dyspnea, orthopnea, paroxysmal nocturnal dyspnea. These are all things that we can see. But that's as a result of the left ventricular failing or going through failure. Eventually, despite the hypertrophy, left ventricle cannot compensate anymore. And when that happens, we have systolic dysfunction, and that reduces the contractility of the heart, and that reduces the cardiac output, and eventually leads to proper left ventricular failure. Now, when that happens, when somebody has reduced cardiac output, especially on, say, exertion, it leads to syncope. So syncope is, as I said, cerebral hypoperfusion. So not enough blood reaches the brain, so the brain shuts down to kind of divert blood from other areas or intended for other areas to the brain. And we will also see chest pain as well, because the hypertrophied left ventricle there's more muscle, isn't there? So there's now more muscle. So this means that there's more oxygen demand. And if there's more oxygen demand, well, there's more need for cardiac output. If there's not enough cardiac output, we have reduced coronary perfusion, and because of that, the heart sends out proteins or hormones to then go on to act on nociceptors, which signal for pain. So with aortic stenosis, there are some classical symptoms that you will see. It's a sad triad. So it is the syncope, angina, and dyspnea. So we discussed syncope already, but essentially that's because we have reduced cardiac output. Angina, because we have reduced coronary perfusion, therefore we have the release of kind of products that will then go on to act on the nociceptors, causing chest pain. And dyspnea, due to pulmonary edema, due to increase in the pressure of the pulmonary circuit, causing fluid to seep out into the lungs. But an early sign of this is fatigue. So, patients are far more short of breath, far more tired, far more, especially doing normal activities for them, and this we call reduced exercise tolerance. And they may become pre-syncopal. Now, pre-syncopal means it's kind of these patients feel very faint. They're dizzy. They're just especially when they get up from their chairs, etc. They might feel quite dizzy and unwell for a momentary period of time, but they do not lose consciousness. Now, with aortic stenosis, again, how do we find out the signs? One of the things that we can do is we can auscultate, and we'll hear a very harsh systolic ejection murmur. Now, this is quite prominent in clinical practice. It's actually quite it's relatively easy to hear. But again, what we do is, in order to confirm if that patient has aortic stenosis or not, we will do an echo. And also I've written slow rising pulse. So especially if you are examining that person's pulse, you will see, it's almost like a sluggish kind of response of the pulse. Right. And it's akin to the delay that you have in the systolic ejection. In terms of investigations and treatment, investigation-wise, once again, your basics, chest X-ray and ECG, right? But the real gold standard in this case is the echo, because we can see the valve area, we can see if there's a degree of calcification, and we can also have a look at the chambers as well. Now, in terms of treatment, now, aortic stenosis is one of the more exciting parts of cardiology now, because interventional cardiologists, one of their kind of key main procedures is TAVI. So that's transaortic kind of replacement of the valve. So what this has actually reduced is cardiac surgeons doing open heart surgery to remove somebody's aortic valve, and we're able to just do this, percutaneously. So we can approach this through the again the femoral artery or the radial artery, and we can then reach go through the aorta and then reach the aortic valve. We can kind of open up that area, and place a little valve to open up that area and increase blood flow. So we don't want to do open heart. We want to avoid open heart surgery as much as possible because of infectious complications or recovery times and things like that. So TAVI is something that is being done far more commonly now. But we still do tissue AVRs or surgical AVRs. If that patient is not surgically fit, if that patient is surgically fit, and two, if the area is below 0.6 centimeters per squared. Okay. And I've also added in that we can give antibiotics if infective endocarditis is suspected. So because of stenosis, you can have jet lesions that can damage the endocardium, and this can have deposits of infected vegetation that can then get infected and cause things like aortitis in the context of aortic stenosis anyway. So another sound clip. So you can see at the peak, it's essentially the left ventricle trying to display such a force that the aortic valve will open all in one go, and all of that blood will enter the aorta at the same time. So if you listen to that again, that whoosh, that characteristic crescendo decrescendo whoosh sound. Okay. Oops. Now, aortic regurgitation, once again, leaky valves, incompetent valves. What kind of changes are we going to see in the heart? We're going to see volume-related changes. So there are two ways this can happen. We can have valve leaflet disease, and we can also have aortic root disease. So in terms of valve leaflet disease, this is going to be caused by the same things we've spoken about before. So rheumatic heart disease, infective endocarditis, and congenitally speaking, a bicuspid aortic valve instead of the normal tricuspid valve. You can also have aortic root disease. So this is where the aortic root, so that area where the aorta starts, it dilates. The aortic valve also kind of dilates or becomes squishy with myxomatous changes. So as I said, like these mucoid, you can have accumulation of mucoid tissue, and this isn't as strong as normal aortic valve tissue that is lined with endocardium. So people with Marfan's, Ehlers-Danlos loss, and other connective tissue disorders could also have this. And I've also added in aortic dissection, which is a proper vascular emergency. So aortic regurgitation kind of predisposes that person to aortic dissection far more than other disorders. So in terms of pathophysiology, we have diastolic reflux. So what that means is that blood from the aorta leaks back into the left ventricle, and this causes blood from the left atria plus this new blood from the aorta to increase volume inside the left ventricle. So this causes volume overload. So the left ventricle would dilate, and it will have hypertrophic changes. And when it has hypertrophic changes, we have an increase in the wall stress, and we have systolic dysfunction. So systolic dysfunction will reduce contractility. It will make the heart stiffer, and therefore, eventually, what will happen is we will have reduced cardiac output, and then we have total left ventricular failure. But anyway, the next thing that happens is that we have reduced diastolic BP and an increased systolic BP, blood pressure. So we have something called wide pulse pressure. Now, why do we have a reduction in the diastolic blood pressure? We have a reduction in the diastolic blood pressure because blood will leak into the left ventricle from the aorta and reduces the aortic diastolic pressure. But the systolic blood pressure increases because you have more end diastolic volume. Therefore, you have to exert. There's more intraventricular pressure, so you have to exert more of a force through systole to eject all of that volume of blood out of the ventricle. In other words, you have more stroke volume. So this difference between systolic and diastolic pressure gives the characteristic water hammer pulse or head bobbing sign, all of these things that we will go on to speak about. So this is one of the kind of things that you will see in the physical exam. So it's that difference, or the wide pulse pressure difference in the two. Now, so all of this will go on to cause reduced coronary perfusion, so less blood flow to the heart. Now, diastole is when coronary arteries will fill. If the diastolic pressure reduces, then coronary pressure also reduces. So there's less blood flow to the tissues of the heart. If that happens, it can first go on to cause angina because the heart is under acute stress. It thinks that it's not receiving enough blood, or it can go on to become an ischemic event because the blood is not. We don't have enough blood being perfused in to the heart, and therefore we can have ischemic disease from that. Now, this can actually progress. So especially if you've already had left ventricular hypertrophy and you've had all of these kind of tissues, or muscle that is produced to deal with the increased intraventricular pressure, or in other words, left ventricular hypertrophy. The left ventricle is now a bit of a mass monster. It has more muscle. It needs more energy. It has an increased oxygen demand. So if we don't have coronary perfusion, we have less oxygen going to the musculature, so we don't have enough blood to meet the oxygen demand of the heart muscle. So when that happens, you can have ischemia, and therefore, if it is really bad, it can cause myocardial infarctions. So this is a way you can have an MI without coronary artery disease. So this is why this is quite dangerous. Now, in terms of symptoms, again, these symptoms are dyspnea, fatigue, palpitations, and angina. So the symptoms are quite similar to other disorders that we've spoken about. But in the case of signs, these are a bit more high yield. These are a bit more like we would be. These come up in exams a bit more. So the wide pulse pressure, we have the collapsing water hammer pulse. We have the Corrigan sign, which is where the carotids are visibly pulsating. We have the Queen Key sign, which is where you have capillary pulsation in nail beds. So when you get the patient's hands out, you can, and when you're testing for their capillary refill time, you can actually feel their capillaries pulsate. And if you turn around and look in their nail beds as well, you can see visibly visible pulsation of their nail bed, within their nail bed, I mean. It's got a very short sound clip here. It's not absolutely clear, but that sound at the end, that trickle, that's the blood going back into the left ventricle. So it's a difficult one to hear. Even in clinical practice, it's quite difficult. Therefore comes in our good old friend echo. So in order to diagnose somebody with aortic regurgitation, if you have that suspicion, we do an echo and also a Doppler along with it. So we can look at the severity of the regurgitation, we can look at the LV size, the function, the valve area, and the overall blood flow. We can do your other basic examinations like ECG, chest X-ray. Another one is we can do a cardiac MRI or catheterize, or send that patient to cath lab. So this is especially if the echo is inconclusive or we want to make a plan for surgery. Medically speaking, so how do we medically manage these patients? We want to give them vasodilators. So especially with ACE inhibitors, bring down the blood pressure. Things like nifedipine, which is very good for the treatment of this. And if there are signs of heart failure, then we will give them diuretics to make sure we can drain the fluid that is building up in their lungs, or peripheral edema as well. Surgically speaking, we can replace their valve. Again, same as what we've spoken about before. We only really do this if they're really, really symptomatic. The aortic regurgitation can occur again. So a follow-up is very, very important. So we can do yearly surveillance by doing yearly echoes for these patients. Okay, so tricuspid valve disease. Now, your tricuspid valve is the atrioventricular valve between the right atrium and the right ventricle. So it's dealing with blood flowing from the right atrium, so the deoxygenated blood flowing from the right atrium to the right ventricle. So the normal valve area for this is about 7 to 9 centimeters squared, and severe stenosis is when it's below 1. How can this happen? So it's usually secondary to right ventricular dilation, so especially from left-sided heart disease, pulmonary hypertension, any infarctions on the right side of the heart, things like that. Um, tricuspid stenosis can occur as a congenital issue as well. And we can also have endomyocardial fibrosis. So again, rheumatic heart disease. If patient suffers from other types of other disorders that can cause fibrosis. Other things include tumors, any kind of valvular dysfunctions, prosthetic valvular dysfunctions, drugs, and radiation. Now, pathophysiology. The pathophysiology again. So, what did I say about stenosis? Stenosis is a pressure-related pressure-related change. That's what's going to happen to the heart. You're going to have changes associated with pressure. Now, when you have a narrow tricuspid valve, a stenotic valve, the right atria has to exert a force that is much higher than it normally is to pass the blood into the right ventricle. So the right atria will dilate and go through hypertrophic changes, and this actually then causes an increase in the backflow pressure of your systemic venous system. So a posh word for this is the central venous pressure. So if you have you want your central venous pressure to be about 8, and you're in trouble if it goes above 12. So if that patient has right atrial pressure, very high right atrial pressure, what you will see is the central venous pressure being higher than that 12 as a guideline number, let's say. And what you'll then go on to see is changes to the organs downstream. So especially your liver. Your liver will go through hepatomegaly. You may also see ascites. So when the pressure inside the inferior vena cava, or wherever the central venous pressure is so high, you have fluid seeping out into spaces, and in this case, you can see it as ascites. So these are some of the things that you can see from your physical exam. But anyway, if you have if you have systemic venous congestion, it means that it prevents the right ventricle from filling properly, and downstream. So now, so that means less volume of blood is being oxygenated, and therefore, what that will cause is that we have a dip in the eventual volume of blood that enters the left ventricle, and therefore that will reduce the cardiac output. So less blood, oxygenated blood, will go to tissues, and we're not able to meet the metabolic or the oxygen demand of our essential organs and tissues. Now, tricuspid stenosis is often dominated by left-sided lesions. So left-sided lesions, so especially things like, as I said earlier in the class, like mitral stenosis, leading to left ventricular changes, which then goes on to cause left atrial changes, which then causes congestion of the pulmonary circuit, causing right ventricle to dilate and have increased pressure. These are it starts from left-sided lesions mainly. But one of the symptoms that I think is often overlooked in clinical practice is the abdominal pain. So it's really important when a patient comes in, you do a head-to-toe examination of that person. So not only are you listening to the heart, but you're also doing an abdominal exam. So you may see, it's not always accurate, but you may see that when you're doing a percussion and you're looking for the borders of the liver, this liver might be enlarged. But a telltale sign of systemic venous congestion is ascites, and another one is peripheral edema. Um, these patients aren't really short of breath. These they can be, but the main things are this kind of abdominal discomfort. You'll see not bilateral. You'll see peripheral edema, sometimes pitting edema in the legs. So these are the things that these patients generally tend to come with. Um, Another thing is, because of the increasing central venous pressure, you may also see the jugular vein um, dilate. So you need to ask the patient, look to the left, look to the right, and just check their jugular vein. Is it dilated? Because this may be a sign that there is a congestion to the right side of the heart. So we can do an echo. Um, we can do an echo again. It's my favorite test to find out the compliance or the competence of these valves, right? And you may, in the echo, you might see a thickened immobile tricuspid valve because of stenosis. But don't forget your basic investigations like ECG, your chest X-rays, because they give a very good baseline of what's going on. In terms of medical treatment, we tend to ask the person to we tend to put them on diuretics because they're quite at risk of having edema, especially in the abdomen, so ascites, I mean, or further down, so you can have pitting edema in the legs as well, because of this kind of backflow. We sometimes ask these patients to restrict salt intake, because when when you put someone on diuretics, something that you have to manage is their sodium and potassium. But it's not, because of how strong diuretics are these days. It's not something that is commonly commonly asked of. But it's just from the literature, this is something that is written. Surgical methods include valvulotomy. Annulotomy is something that you do. So if you remember from our previous class, I spoke about the cardiac skeleton. So you kind of make a hole within the cardiac skeleton and then replace the valve. But it's not often that you do that, and you do that only if there's severe tricuspid stenosis. We try to treat the cause instead. So, for example, if it is rheumatic disease that is causing this, we do we give rheumatic prophylaxis. If it is a carcinoid tumor that's causing this, we give octreotide. So things like that. But mainly we give diuretics, and we sit and watch how this patient is doing. And we can also do an echo every year just to see how what their valve area is doing, and the size of their chambers as well. So you tend to do that every year. Now, one of the things that I wanted to mention is that tricuspid stenosis, the sound of that is very similar to mitral stenosis. Oops. Oh, so this one is not working, but it's very similar to the mitral stenosis. So these videos that are in this PowerPoint will be shared with you. But I think it's very good revision. So when you do an auscultation on patients who come in with tricuspid or pulmonary valve disorders, it's quite difficult to differentiate what differentiate that sound, what kind of a murmur they have. So in this case, your echo is a very, very good friend. So I just wanted to mention that. Okay. Moving on, we have tricuspid regurgitation. So repetition, repetition, repetition. But regurgitation, we're going to see what kind of a change with the heart, volume related change. So with regurgitation, it usually happens secondary to right ventricular dilation. Again, it's downstream from left-sided heart disease or pulmonary hypertension mainly. Now, in terms of an etiology, we have primary organic causes and secondary functional causes. Organic causes are mainly the ones that solitarily affect the tricuspid valve. So rheumatic heart disease, infective endocarditis, congenital problems, trauma to the heart. Now, in terms of secondary functional problems, we can have right ventricular dilation as a result of left-sided heart disease, pulmonary hypertension that causes right-sided dilation, and again, as a result of left heart disease. And also chronic AF can also cause tricuspid regurgitation. Now, the logic behind this is that the tricuspid valve is incompetent, and therefore, the blood from the right atrium, although it does flow into the right ventricle during systole, we have some of that right blood in the right ventricle flow back. Now, you can have the backflow of blood from the pulmonary vein come back in through the pulmonary valve into the right ventricle to increase the volume in the right ventricle, and this blood during systole can kind of just seep into the right atrium, and over time this can cause right atrial and right ventricular enlargement. And then, as I said before, if there is hypertrophic changes to the right atrium, this can then cause systemic venous congestion. In other words, increase in the central venous pressure. So there's more pressure the vein has to, exert to overcome the pressure changes within the right atrium. So that pressure can cause fluid to seep out into various spaces within the body. So in the case of the right side of the heart, we have it in the abdomen and go on to cause ascites. So signs and symptoms, it's all the usual stuff. So fatigue, weakness, dyspnea. We can also have peripheral edema. The difference here is that you can have abdominal symptoms such as ascites, or the patient saying that they feel very bloated. In terms of signs, so this is where, as I said, the jugular venous distension. So you can examine the patient's jugular vein by asking them to turn their neck to one side, and you can see if it's distended or not. Hepatomegaly is another one. So on your abdominal examination, the liver may seem rather large. Peripheral edema and other things include ankle swelling, sacral edema. Sacral edema is not really that easy to see, but ankle edema is 100% easy to see in your clinical examination. So this is a feature of right-sided failure. And the murmur, again, it's not easy to hear the murmur because it's quite similar to mitral regurgitation. It is called a holosystolic or a pansystolic murmur. One of the ways you can differentiate that is that it increases with a deep breath. But again, it's quite hard to hear that. Once again, in terms of investigations, we do echo. You do your basic examinations like ECGs and chest X-ray. Something to note with the ECG is that this patient may have a right bundle branch block that you can see in the ECG. But from that, this patient may go into AF. But these are just basic examinations to do. You can also, if you have the facilities, do a cardiac MRI. In terms of treatment, again, diuretics. you want to make sure these patients are kind of release the fluids that are building up in their abdomen, in their ankle, in their lungs. You want to treat the underlying cause of this regurgitation. And if surgery is required, we will just repair or replace that valve. But mainly it's done for very severe symptomatic patients with no other causes that we can find. So another little sound bite. So as you can see, it is difficult, but essentially because it's quite similar to mitral regurgitation, but I'm just leaving that there just so that you can have an idea, have a little think about it, and just for your general awareness. Now, pulmonary valve diseases. So the pulmonary valve is between the right ventricle and the pulmonary trunk. So this is moving deoxygenated blood from the right ventricle into the pulmonary circuit to then go on to get oxygenated and be brought back into the left side of the heart to enter systemic circulation. Pulmonary stenosis is pretty rare, and it's mainly from congenital causes. So it is one part of the tetralogy of Fallot. So that's the most important high yield thing to learn from pulmonary stenosis. You can also acquire it from rheumatic disease, carcinoid syndromes, and sometimes post-surgery as well. The pathophysiology is that if you have right ventricular outflow obstruction, the pressure we have the pressure overload of the right ventricle. Therefore, as I said before, stenosis, meaning it goes through pressure-related changes. So the heart goes through pressure-related changes. The right ventricle will undergo hypertrophy, and because of this new right ventricular hypertrophy, the right atria has to compensate by also enlarging, by also going through changes. What then happens is that you have less volume of blood going into the pulmonary trunk to get oxygenated. So what that means is that you have less, at the end of it all, you have less cardiac output of good oxygenated blood, and therefore you have less perfusion of tissues, and this patient will come in with symptoms of fatigue and reduced exercise tolerance, shortness of breath, things like that. That I guess that leads me on nicely to talk about symptoms. So fatigue, exercise tolerance, dyspnea on exertion, and especially so with congenital heart diseases, something that you will see is cyanosis, because not enough blood is reaching the peripheries of the body. So not enough oxygenated blood, excuse me. So if you have peripheral cyanosis, you'll see cyanosis or blueness of the fingers and toes. If you have central, it's mainly the lips. So this is a very, very bad sign. We don't want any sort of cyanosis to happen, because the next step to that is necrosis, and again, that's bad. That's basically tissue death. In terms of signs, we may hear a systolic ejection murmur, but it's quite hard to hear that. We may hear an increase in the sound of the murmur with inspiration, and we may have a right ventricular heave. So this is where the right ventricular there's like this delayed flow of blood into the pulmonary trunk. So there's a delayed flow, and then snap, loads of blood flowing in at the same time. So, but as I said, it's quite hard. This is why, once again, stick with the echo. Echo is the best way to see if that patient has pulmonary stenosis or not, because of how varied or ambiguous auscultation can be in terms of the murmur that you hear. We can do an ECG, we can do cardiac, we can do a chest X-ray. These are again basic examinations, and we can also consider cardiac catheterization, but it, specifically written is quite rare. Now, in terms of treatment, usually observation is enough. So you don't need to do too much, especially because it can be difficult to do much. But if it is moderate or severe, what we try to do is a balloon pulmonary valvulotomy. And if if it is really necessary, an open heart surgery, especially if this person's anatomy is unsuitable for a balloon. Right. The next one is pulmonary regurgitation. Okay. Another bit of repetition. Regurgitation, volume overload changes to the heart. That's what you're going to expect. So pulmonary regurgitation, there are a couple of ways this happens. We have functional problems. So we have so this is usually secondary to pulmonary hypertension and right ventricular dilation. We can have it after surgery. So especially after the repair of a tetralogy of Fallot or pulmonary valve replacement, you can have incompetence of that valve. And then other causes include infective causes, rheumatic disease, etc. In terms of pathophysiology, we have, again, backflow of blood from the pulmonary trunk into the right ventricle, plus the blood coming in from the right atrium going into the right ventricle. These two together causes a volume overload. This forces the right ventricle to dilate, and this causes a volume overload related changes to the heart, and this goes on to cause systolic dysfunction, reducing the volume of blood that goes and gets oxygenated, and it goes on to cause right-sided heart failure. And the knock-on effect of that is that we have reduced cardiac output from the left ventricle, with less volume of blood going to different tissues as we want. Signs and symptoms. Once again, fatigue, exercise intolerance, dyspnea on exertion, so shortness of breath on exertion. We will see peripheral edema because of the right-sided congestion, and abdominal fullness or ascites or hepatomegaly. In terms of signs, you may hear an early diastolic murmur at the upper left sternal border. You may hear a splitting of the second heart sound if it is quite severe. And again, a right ventricular heave if it's quite chronic. But your best friends here are, your physical exam in other ways. So your signs from your abdominal exam, if there's any peripheral edema, your jugular venous distension, you should examine things like that, because they're the signs of they're the signs that this is moving into moderate or severe category, this pulmonary regurgitation. In terms of investigations and treatment, what you should really do is echo, Doppler. I've said it to death. These are excellent. These are the gold standards for diagnosing this. Your basic examinations like ECG and chest X-ray, and also a cardiac MRI if you have that facility. In terms of treatment, if this person is mild or asymptomatic, it's better to surveil the patient. It's better not to. We don't want to go straight in and do a valve repair. We only do that if they're symptomatic or severe. So we can do surgical or percutaneous options if it is quite severe. But what we try to treat is things for volume overload, so diuretics for volume overload, and any antihypertensives for hypertension. Right. So that was long. So I hope you're all awake. Are you all awake? I've got a couple of questions, MCQs as well. If you could have a read and just pop in the chat, what you think the answer is. There are no right or wrong answers. We're still learning, so don't worry. Don't be shy. Put your answers in. So we've got a 40-year-old woman presenting with pansystolic murmur radiating to the axilla. Which investigation would best assess the severity? A chest X-ray, B, ECG, C, echocardiography with Doppler, or D, cardiac MRI. Um, oh, also have an E as well, troponin. The correct answer is C. Great. Well done both. So to investigate what kind of valvular lesion is going on, echo is the best. So troponin is a prognostic factor to see if somebody is going to have a cardiac event or not. But an echo is very, very good at easily imaging the chambers and the valves, and it's the best way to diagnose somebody with a valvular disorder. Right, second question. A 72-year-old man with severe aortic stenosis reports exertional syncope. Echocardiography shows aortic valve area of 0.7 centimeters squared and a left ventricular ejection fraction of 45%. What is the most appropriate management? A balloon valvuloplasty. B, a transcatheter aortic valve implantation. C, a surgical aortic valve replacement. D, a beta blocker therapy. Or E, annual echocardiography. Yeah, great. The answer is B. So we do TAVI because for anything below 0.6 centimeters squared, we can, of valve area, I mean, we can perform a surgical replacement. But if the patient is a high risk surgical patient, TAVI is now the preferred option. You will see in most cardiac centers, literally this this kind of line of work has been taken over by interventional cardiologists, and TAVI is done very, very commonly now, because and with excellent patient outcomes as well. So a rule of thumb is anything below 0.6, consider surgery. Right, question 3. A 35-year-old woman with rheumatic mitral stenosis presents with progressive breathlessness and atrial fibrillation. She is symptomatic. She is otherwise fit and well. What is the most appropriate next step? A, rate control and anticoagulation only. B, open mitral valve replacement. C, percutaneous balloon mitral valvotomy. D, mitral valve repair surgery. Or E, loop diuretic therapy alone. The answer is C. So we do a valvotomy. The key things from this question is that she's symptomatic. She is 35, and we don't want to, she is a young patient, and it is always preferred to rate control and anticoagulate. But if the symptoms are progressing, it is not unreasonable to replace the valve as an elective outpatient. Um, and since she has rheumatic heart disease as well, the valve is going to get progressively more non-compliant anyway. The mark of a good surgeon is to know when not to do the surgery. But in this case, if they are already progressing, if they are already just not doing well, then considering a valvotomy is the best choice. Okay. A 52-year-old man with mitral regurgitation is found to have a pansystolic murmur radiating to the axilla. He is asymptomatic, but echocardiography shows severe regurgitation, normal LV size, and ejection fraction of 60%. What is the most appropriate management? A. Watchful waiting with regular echocardiography. B. Immediate mitral valve replacement. C. Beta blocker therapy. D. Mitral valve repair surgery right now. Or E. Anticoagulation. Have a little think. So especially think about um, whether he is symptomatic or not. So yeah, we will do watchful waiting. Okay. Now, I saw one of my colleagues has written C, beta block therapy. That is something else that we can do. So we will medically manage this patient with anticoagulation and beta blockers anyway. So I presume presume that because we already know he has mitral regurgitation, he's probably already on medication. I know it's not 100% clear from that question, but the main thing here is that he is asymptomatic. He has severe regurgitation, but what should we actually do in this situation? Well, it is we will watchfully wait. Now, asymptomatic severe mitral regurgitation with preserved LV function, the indication is conservatively manage that. Unless we have LV dysfunction or other symptoms develop, we don't need to think about interventional therapy just yet. Okay, because if you have a look at the question, he has a normal LV size. Okay, so given continue his medications, give him some time, and regularly surveil him, with echoes. So I would say the interval period of that is every 6 months if he is otherwise comorbid, and every year if he's otherwise very fit and well. Okay, I think this is the final question. But a 74-year-old man with multiple comorbidities is diagnosed with severe symptomatic aortic stenosis. He is deemed to be high risk for open surgery. What is the best treatment? A. Medical management only. B. Surgical aortic valve replacement. C. TAVI. D. Balloon valvuloplasty. And E. Beta blockers and ACE inhibitors. Aortic stenosis. So we would do TAVI. So that's what we do for aortic stenosis. But good effort. So we balloon valvuloplasty we can do, but when TAVI's new, TAVI's much safer patient outcomes. So we would do TAVI. But just for your own information, just before this man, we come to a decision to do TAVI, we will have an assessment of his valve area. Think about whether his valve is savable or not. So if he has an area less than 0.6, then as I said before, we will surgically repair that. But the thing is, he's not really deemed to be a candidate for open surgery. So if it is that case, we would have to medically manage him because he may be too risky for a TAVI as well. So a couple of considerations. That's why I stuck this question in there. Oh no, it's not the last question. Right. So a 60-year-old man with mechanical aortic valve replacement asked about long-term management. Which of the following is essential lifelong treatment? A, aspirin only. B, warfarin anticoagulation. C, clopidogrel. D, no anticoagulation needed. Or E, direct oral anticoagulant, DOAC. Yes. Yeah, warfarin. Um, Mechanical valves require lifelong warfarin. DOACs are contraindicated. It is the bane of my existence. So when you're working a medical job, basically 20% of your life is going to be balancing people's warfarin doses and their INR. It's not fun, but this is because they may have a mechanical valve. So this is a little summary of all of the kind of diseases that we've spoken about. I've put in aortic sclerosis in there as well. That was just for my own, it's just my own note. Have a look, just take a picture of that and, have that stored away somewhere just to, just refer back to. This is just to talk about the murmurs and what causes it, and anything else that you need to think about as a high yield option. So I'll give like a couple of seconds for that. Okay. Guys, thank you very much for listening to this class. Please do provide some feedback. That'd be really, really good. I appreciate the stamina that you guys have shown to stay with me throughout this class on a Friday night as well. So thank you, thank you.
Thank you,